Hi, I'm Harry Jacob, the Chief Medical Editor of HEMONC today, and we're very pleased to have join us for this series Dr. Max Koppas, who is the Executive Director of the Center of Cancer and Blood Disorders at the Children's National Medical Center in Washington, D.C. He's also professor of medicine at Pediatrics at Georgetown University. And we're delighted that he is our section head for our division in HEMONC today for childhood cancers. Max, because of people like yourself, the life expectancy of children with malignancies markedly improved over the last 2, 3, 4 decades, meaning that pediatricians who take care of these patients have to, at some point, give them up to adult practitioners for their ultimate follow-up and some of the problems which unfortunately we're beginning to recognize 10, 15, 20 years down the line of childhood survivors of malignancy from the therapies that they've undergone. You've given a good deal of thought to what the problems of this transition might be, and why don't you review some of those, and if you've got any suggestions for ameliorating some of these transition problems, of course we'd like to hear that too, but let's hear about the problems that children have when they grow up and require a follow-up from physicians that they've not had in the past.
Well, thanks, Harry, for giving me the opportunity to talk about an area that is becoming an increased challenge for the pediatric oncology community. So in the last 40 years, 50 years, overall survival for childhood cancer has kind of moved from 10 to 75, maybe 80%. And as a result of the great success, we're now in a very luxurious position that we can determine what the long-term outcome is, not only in mortality, but in health status of these patients. As it turns out, these patients have an increased risk of morbidity, of premature mortality, and decreased health status. There's a recent article in the New England Journal of Medicine, an extremely good article, that shows that children treated between the 70s and the 90s, to take a cohort of these patients, 75% will develop chronic disease by age 40. And of the 100% of all those kids, 40%, so the half of the 75%, will have serious chronic disorders. So what are we talking about? We're talking about serious cardiac malfunction, renal malfunction, dialysis, chronic lung disorders, serious disorders. These are staggering numbers.
How about cognition problems?
So what are the 3 most important side effects of morbidity after treatment? There are neurocognitive disorders, cardiovascular disorders, and fertility. Those are the numbers 1, 2, and 3. And a lot of people would associate neurocognitive dysfunction with children that have had a brain tumor. As it turns out, the most common form of cancer in children, leukemia, a large proportion of patients, 75% of those patients, even in the era now where they're not receiving standard craniospinal radiation, but only methotrexate, 75% of these patients have neurocognitive dysfunction. So this is a serious problem that these patients are experiencing. I briefly mentioned to you that we are embarking in the pediatric oncology community. In the next coming months, we're embarking on what a lot of us think is a very exciting study. It will be the first study to see whether a medical intervention, a drug, is able to improve neurocognitive function in children that have been treated for brain tumors or leukemia. More to follow. But this is a very serious area. Cardiovascular disease, a lot of people are aware that anthracyclines result in serious cardiovascular disease, but mental radiotherapy for patients with Hodgkin disease also results in serious cardiac problems. So The problem that we face is that a lot of these children become teenagers, become young men and women, and then also move away. So they're not being followed in their childhood cancer center, in the pediatric oncology center, but they go and study somewhere else, to college, and find their primary care physician. Most of the communication of what exactly was given has been between the oncologist and the parents. And so you get a dissociation not only in location, but also in where the information went to. And then there's not a specialty there. In internal medicine, people are trained specifically to look at disorders that occur in a normal population. It's more and more becoming looking at geriatrics as well. But there's not a specialty that actually studies or looks at a large cohort of patients that have received chemotherapy. And so one of the ideas that has been suggested is a dual training in pediatrics and internal medicine to specifically look at these issues.
I'm glad you mentioned that. The best and the brightest of our residency program at the University of Minnesota, as far as I'm concerned, are people now involved in a joint training program in both pediatrics and internal medicine. And these have been spectacular kids. It's a small group, but it does strike me that they're going to be the ones that might be most beneficial in taking care of some of these long-term survivors.
These are going to be the leaders in our country that will help primary care physicians. They will guide primary physicians as to what it is that needs to be done. So I think there's going to be a cohort of students, and I'm extremely happy to hear that your same thing is happening in Minnesota. There's going to be a small group of individuals that will kind of transition that gap between pediatrics and adults, and hopefully using evidence-based medicine, provide guidelines as to how do you follow these patients, how often, what are the kinds of things that you need to look at.